spread it already. Yeah. Thanks, Edita, for that. I didn't take that to be an introduction of me in Swahili because I couldn't catch some words. But most of you know me as Charles because I think when I was growing up, being called a doctor was such a phenomenal thing. And you would find this man in a white coat with a stethoscope wrapped around their neck. They look at you and then they scribble a prescription and you go. I lived when we only had malaria, so most of the times we would get well because they gave us jabs of chloroquine. I didn't realize that in 2020 chloroquine will come back and would be popularized by Mr. Trump. So I've been asked to talk about assisted reproductive technologies. I hope I read that fine. But I wasn't very sure how to make a presentation, so I decided I spend most of the time teaching in the university and making slides. It will be very boring to make it too formal. So maybe I'll just talk, and if I blubber, you just have to excuse me because I'm not used to free speech. But I'm never ever pleased because when I go out, a few times now, I always get these messages from my patients. So this morning, I think I'll read one. It said, "Morning, doc. Hope all is well on your side. I was to test on 27th, was kind of a bit anxious. I did not, but I did test today. I guess it is positive. I cannot believe, I thank God for that. Thank you for everything. Please advise further." So this is a message that is following an IVF treatment cycle. And my patients know that they don't have to come back for a blood test. They will do a test at home, and they will communicate back to us. We want strips. Yes. It makes it much easier. You're much in control. You decide when to do it. And of course, you can only do it if you're prepared. Like this lady was meant to test on 27th November. It took a week. Continued with the tablets, of course, did not stop. Didn't see a bleed, and then thought, maybe something is happening inside me. Let me just give it a try. So what is assisted reproductive technologies or techniques? Technically speaking, it's terminology that is used when you manipulate eggs and sperm outside the body. So it involves what we call in vitro fertilization, or IVF. It involves what we call intracytoplasmic sperm injection, or ICSI. It does not involve intrauterine insemination because we don't handle your eggs even though we may place sperm in the womb. Anything that enhances natural conception inside the body falls outside the scope of assisted reproductive technologies. But I will still speak about IUI to an extent. Now, we've come a long way. You might have heard about things like gamete intrafallopian transfer, gift, from many years back. And they had a place before IVF had more than 10, 15. It was an option, particularly for those who had concerns or objections against IVF. Now, why do we recommend to go the route of ART or assisted reproductive techniques? The indications keep broadening. It was invented because originally we knew that natural conception only happens when a lady releases an egg and there is sperm from the man that meet during sexual intercourse. So the fallopian tubes had to be open or patent, as we call it. When the tubes were blocked, that process could not happen. So we had to find a way where we can bring the egg and sperm together. And I don't want to bore you with the history, but a gentleman called Edward Steptoe, the pair, worked so hard, and they discovered that you can actually replicate these processes in the laboratory we use little tiny dishes, and that's why the term test tube baby comes from. It's not an engineered baby, because we just get your egg, we get sperm, put them together, enable them to grow the way they would, and then very carefully place them back in the womb when they should have been. Then they start growing there. Okay. So tubal damage was the only indication originally for assisted reproduction, or IVF for that matter. We knew that if the sperm count was low, there was nothing. The techniques used then were you take an egg and sperm in a dish and allow them to fertilize naturally. So that was called in vitro fertilization. Those who had low sperm count or no sperm at all then did not have an option. But later in the 90s, we discovered that you can break the tail of a sperm, because sperm are usually very vigorous and they're swimming around. So if you pick it and place it in an egg, it will swim itself out. Well, it does damage it, it will not swim out. So we break the tail, we immobilize it, and then we inject it directly. So that's called ICSI, or Intracytoplasmic sperm injection. It was a huge, huge, huge breakthrough, because we expanded exponentially the indications for ART, and we could include male factor as an indication. What most people don't realize is that we deal with a couple who are trying to get pregnant, and if you break it down into causes, 50% of the time they will be related to the boy, and 50% of the time the causes will be related to the girl. Even though a lot of people would come to clinic and say, I would like you to test me just to make sure that I know I'm okay, and if there is a problem with me, then I know that's the reason why we are not getting pregnant. My partner hasn't come, or they are not willing, or sometimes they will say, well, he's got a child. So there's a lot of dynamics with reproduction, that you can have a baby previously, even girls, and then you're trying for a second one and it doesn't work. Even when there is no obvious cause, we call it unexplained subfertility. So we've expanded the indications, and now we are looking at things like, if you don't have a diagnosis that is definite, so tubes are fine, you're ovulating naturally, and the sperm count is normal, but it's just not happening, why isn't it happening? So this falls back to very basic principles, that if you are fertile and we tell you, on your marks, get set, go, and you're 100 of you, each month of being fertile, only about 7 of you will come back pregnant. Yeah. So we call it fecundity. So it's something that a lot of people, including doctors, do not know, because all of us are socialized and told, don't have intercourse because you get pregnant. Yes. And the time you want to, you realize, one of my patients, I think she's now, I think she might be about 19 weeks pregnant now. She came and said, I didn't realize it's hard work to get pregnant. It is work to get pregnant. Yeah, so even when everything looks perfectly okay, it takes time. Every month of fertility, you only have about 7% of normal couples getting pregnant. And if you stretch that over a year cumulatively, you have about 80 to 85% chance that the 100 of you will come back with a positive test. So it leaves about 15 of you who haven't conceived in the first year when you've been trying. Now, what does that mean? If we give you more time, the 15 who've remained, and told you another year to try, generally you will find probably just a half of you have conceived in the second year. So if you take the original 100 and you follow them for 2 years and there was nothing wrong with them completely, only about 90 to 92 of you will get pregnant. What does that mean? That natural conception does happen, but it is very inefficient. Why is it inefficient? We don't know. But, we look at things like you release one egg, it's got a very good chance to fertilize, but we know that men must have millions and millions and millions of sperm for 1 to fertilize 1 egg. So those are some of the things at play. If you've been trying to conceive longer than 2 years, and you look at our original 100 couples who are trying, 95 of them have conceived by the 2nd year, so we have 5 of them. If you try to give them a chance to conceive naturally, whatever you are doing, their chance of getting pregnant is really, really small, and it's less than 5% in the next year. So generally speaking, after 2 to 3 years of trying, then you have to weigh your odds and say, what can we do to give ourselves a better chance to get pregnant than to continue naturally? Of course, you may continue. It doesn't mean you can't. But statistically speaking, then you have to look at your options. Now, we have something called intrauterine insemination. And most of you will have heard of it. Perhaps some of you might have heard it. It does work. It's got its place. But it's just as effective as trying to conceive naturally. So it doesn't increase your chance to get pregnant if we take semen sample and put it in the womb at the time of ovulation. Because what we are doing is what you do at home, but we charge you for it. Okay? There are clear indications, though. Don't get me wrong. There are times when it's not possible at all at home. Then there would be a reason to do it in the lab with us. But if you're doing it at home and everything is okay, then you really have to think through and say, Doc, what is the chance that if I did an IUI cycle is going to work? And generally speaking, in the best circumstances, and if you've been trying for less than 2 years, you have about 10% by every cycle. So cumulatively, if you really need IUI, you need to do at least 3 to 6 of them to give you a chance of about 30 to 50% that it will work. Yeah. So you looked at your odds, and you have to choose your options with the right information. But what saddens me is a lot of girls go through procedures without full evaluation. You cannot have an IUI procedure without knowing if your tubes are open, because you are trying to get the egg released and then it will meet the sperm and perhaps fertilize. So you mustn't have an IUI procedure without checking your tubes. There are different ways of checking tubes. Some are sophisticated, some are simple. You can have the age-old HSG. It is horrible, painful. And I know most of you will hear the word and something just runs, down your spine. I think what's distressing is if you have an HSG test that brings back a report, you shouldn't really do it several times to check whether that report was correct or not. So HSG, HICOSI, as we call it, they are tests that are screening. So like any screening test, if it's normal, it's good. You're kind of pleased with the results. If it's not normal, don't repeat the same test. I'll give you an example. I was in medical school when we started seeing HIV patients, and we started off by something called syndromic identification of patients who are likely to have AIDS. So AIDS came from looking at someone, they are wasted, they are being unwell, and they fit this syndrome. So we called it acquired immune deficiency syndrome. So you ticked boxes. And then you did a test, which were called rapid tests. And if it was positive plus all these other symptoms, then you think, yeah, this person must be having HIV because, but not everybody who had a positive test actually had HIV. Because we know now that there are things like cancer which might present in the same way. You might have tuberculosis and you're just wasting away, and we think you've got HIV. But of course, it's true that people with TB might have HIV. So when we used the rapid tests, they are designed to catch as many positives as possible. But if one turns positive, you must confirm it. So you won't just take that to be a positive. And that is very similar to doing a tubal test. So if you have an abnormal HSG, then it means that there must be another test to confirm that abnormality. Unfortunately, some of the tests that we need to do to confirm are invasive and expensive, so you will need a laparoscopy to check indeed if your tubes are damaged. because they may actually as well be normal, but the HSG says they are damaged. You don't quite doubt an HSG when it says, well, your tubes have got this fluid in them called hydrosalpinges, because that one is quite clear, even seen on ultrasound. But if it says proximal tubal blockage, or we couldn't see the dye spilling over the other side, take it with a pinch of salt. And you'll have many stories you hear. You hear people say, well, my doctor said my tubes were blocked and, God did his miracles. It's true, but it's because the test was not 100%. Your tubes are actually normal. So you have to think through with your doctor and say, what does this mean? And don't just rush to tell me, well, I need IVF, because you may as well have been trying just 6 months. So give yourself some time, check that it's actually true. If it's longer than 2 years, then you have to go back to the original data and say, well, even if the tube may come back normal, what is the chance that we are going to be able to conceive? We did a survey many years back. I think it might be out of date, but I still quote it. 50% of consultations that go to gynecologists are related to fertility. And a lot of the diagnosis was tubal or male factor, meaning there's a place for IVF. But IVF is not always accessible to everybody. Yeah. First of all, we talk a lot of jargon. We'll be telling you embryos, blastocysts, this and that, and you completely have no clue what we are saying. But then we say it costs you this much, and you're thrown off balance completely. But what does IVF actually entail? So the process of going through assisted reproductive techniques is actually what happens in your body. We just do that outside. A little bit of it inside your body, but some of it outside. So we will mimic a natural cycle. But because natural cycle can only produce one egg, we're interested in numbers, because statistically speaking, even if you went for a lottery, would you like to be betting when you know that my odds are this small on one, or if you can have many? So with IVF, we rely on numbers of eggs. So if we have more eggs, the better. And what we do to achieve that, we have to switch off your natural processes first, and that's called downregulation. So we have 2 protocols. One is called the long and the short. So the long protocol starts by switching off your ovaries around mid-cycle or day 21, classically. And then once that is achieved, it's a kind of medical menopause, but it's very temporary because your ovaries will not be switched off permanently. Once that's been achieved, then we give you hormone injections for about 10 days on average, and we monitor how the eggs are growing. We call them follicles on ultrasound. And when we do that, it's exactly what will happen in your body, but because we have switched off your hormones, so the natural regulation to have one egg dominating is taken away, then you have many coming up. When they reach the right size, then we give you something called the trigger injection or the late night injection or HCG, whatever you call it. Now what that injection does is to mature the eggs, because the eggs cannot fertilize if they aren't mature. And it takes about 34 to 40 hours before the egg collection on average. And when we get the eggs from your ovaries, then we get a sample of sperm, either from your partner or if you're using donor sperm. Then we will inject them, or we will incubate them together in the dish and keep them in the laboratory in a very special incubator. Very warm in there, cozy, not as cold as here. Okay? And the aim is to allow this egg and sperm to fertilize and then create what we call embryos. That process is very delicate. It's extremely delicate. And because of the high number of eggs that we might have retrieved, not all the eggs are of the same quality. Some are good, some aren't good. Okay? Some may fertilize, some may not fertilize. And those that fertilize, some may still be abnormal, but they will continue to grow and divide. But it's a very, very, very intricate and interesting process that as the cells divide, embryos that are not normal will be slow, they stop, or they do what we call fragmentation. So if we keep them for 3 days, they also can be very difficult to tell apart which one is normal, which one isn't very normal, because at that point, they are almost similar, and there will be about maybe 6 to 10 cells. So to tell a difference between normal embryos at that stage cannot be very easy. So we push them on to day 5. We call it blastocyst stage. And that's the optimal time, if you look at your natural cycle, when the womb is also very ready to receive the embryo. So those that would not have been good enough will not move to blastocysts. A lot of times they will be stagnated in development around day 3. So, you select them against them immediately. And those that have moved on to blastocyst stage will be telling you that I have 50% chance that I'm a very good embryo. And you have to be very clever to actually find me. And our embryologists have to work very hard. So if you have only 1 or 2, the job isn't very difficult for us, because then we'll replace those ones. But what is the chance that an embryo at day 5 is going to make a pregnancy? Because half of them may look normal, but genetically they are not normal, then you have about 50% chance that if you transfer the embryo, it will be a positive test. But the odds are better, because it's like tossing a coin. If you toss a coin and ask you, what's the odds that you'll get head or tail? It's 50-50. So if you get your embryos to day 5, you are in a much better position than if you have your embryos at day 3, because at day 3 embryos, most of them may still not be very good, and they may not move on. Now, one of the issues that has been nagging the IVF world, including patients, is how do we actually improve our pregnancy rates? And blastocyst culture was one of them. There are things like getting cells from the embryo, we call it biopsy, and testing genetically normal embryos. It's been very disappointing because it's not telling us the results get better, so it's probably a waste of time to even biopsy them. And there's also a tendency to say, can you actually put more so that my odds improve? I don't know how many of you are statisticians, but you remember a little bit of maths. Yeah, so the odds are not adding up when you go to day 5. So what happens is, if you're looking at the chance that you're going to get a positive test, we call it a binary outcome. It means it's either positive or negative. So if you put more embryos, your chance to get one or the other does not change at all. Yeah, you either will get a positive test or you have a negative test. But what changes is the chance that you will get multiple embryo implantation as you go up. So if you have one embryo that is very good at day 5, sometimes it will split and make 2, but that to happen is about less than 1% chance. So you'll be very lucky that your embryo on day 5 will split and you have twins if it's only 1. But if you have 2 embryos on day 5, if you want to know what is the chance that you are going to get pregnant, if with 1 it's about 50%, with 2 it's about the same, or maybe 55%. But if you have a positive test and you had 2 embryos, you have 50% chance that a positive test will give you a multiple pregnancy. Now, if you put more than 2, obviously you may get a positive test, but your odds of getting multiple pregnancies is significantly improved, or it's not really a good outcome, because if you get 3, 4, 5 embryos implanting, then your chance of getting a live birth starts to drop. So if you draw 2 graphs, if you look at live birth with 1 embryo on day 5, it goes like that. If it's 2 embryos with a live birth, it's slightly higher than the 1. But if you have day 5 embryos with more than 2 embryos, your live birth starts to come down, which is an irony because it means you get pregnant, but you are less likely to get to term because of the complications that come with multiple pregnancy. Now, what does that mean for us? It means that if you have embryos that have reached day 5, you can have 1 or 2 put back, but we can keep away some for you. So you don't have to feel at a loss that what happens to the rest. Because we now are very clever. We can stick them in the freezer, and then you can come back later. So my consent forms say, how long would you like to freeze your embryos for? We'll say 5 years, 10 years. We've got a 55 there, but 55 is usually quite optimistic and more reserved for people who are coming for fertility preservation, for example, if you have cancer treatment or something like that. So you can keep your embryos. They don't age. So if you have an embryo that is frozen when you're 30 and you come back to use it 10 years later when you're 40, the embryo behaves exactly like a 30-year-old embryo. It doesn't change at all. The other thing that to remember, and question I get asked is, what is the quality of this embryo when I'm going to use it when it's been frozen? The quality doesn't change, so we use the original freezing criteria. So your embryo is not going to change in quality once it's been thawed. Although it's a little bit of a stressful process to freeze thaw embryos, but more than 99% and 95% of the times, embryos that were day 5s, meaning they were good quality, will survive the process of thawing. And incidentally, actually, they may have slightly higher rates of pregnancy compared to those that weren't frozen. Okay. So I think I've kind of taken you through a bit of a journey of what happens in IVF. I don't want to delve into the details and jargon, and I'll be happy to field some questions. I've deliberately left the area of implantation just to the Q&As because implantation failure and all that it's a very interesting topical area, but I wouldn't give it justice to talk about it for 1 minute.
Thank you, Doc, for the sharing. I'm a victim of a failed IVF, and even as our ladies who have had miscarriages say, I have a loss because there was attachment, because this is part of you which was taken. And before the transfer, you are asked to see the embryo through the screen. So you feel that you've had a loss. So the question which I would like to ask, are there advanced tests to be done for the embryos to know if there are deformities? Because you do a transfer, like in my case, I had very good embryos. The doc said they were of high quality. My uterus everything was okay. Then it failed. Now, I haven't gotten the courage to go back to the doc, but I've been reading a lot. So at some point, Dasa said Dr. Gugu is also a friend. So I've been doing a lot of research and studying about it. And I read something about embryo deformities and some tests, which I don't know if they're currently done in Kenya or not. Then the last question, do you in Kenya, do they allow embryo transfer? Because at some point you may feel you are not handled well after the results. Because most clinics, or some clinics, they don't even offer you the counseling after the failed IVF. Unaambiwa, it didn't work, sisi hatujui. We don't have a proper, and I believe that just the way you are counseling me before the transfer, you should equally handle me well, even after the failed IVF, for me to get just a little hope to make a step. Then about the surrogacy. Approximately, if somebody is considering that case, what would you advise on the cost? Probably.
Thank you. Such a short memory, so I'm not sure I'll take more, but I'll try one by one. So, see that top quality embryo, but it still has just 50% chance that it's going to implant. And that's what I was talking about earlier. Can we test? Embryo quality is a function of its genetic competency. So you have an egg which carries a set of chromosomes, and you've got sperm which carries a set of chromosomes. And they have to mix, divide, and then these chromosomes are shared amongst each cell as it divides. The commonest cause of an abnormality will be the wrong set of chromosomes moving around the cells. It tends to be very random, so it has nothing to do with you. So an embryo is not inheriting anything abnormal from you, but this is a very delicate process, but it's fraught with a lot of irregularities. So does testing help? There were original studies that said, yes, if you get what you call euploid, we call them, as opposed to aneuploid, which are abnormal, then you improve your chance that you get pregnant. But we know that for you to test for that, you need to biopsy the embryo. So biopsy means taking a few cells from the embryo. When do you do that? The best time to biopsy embryos is on day 5. So already the ones that are not good enough will not reach day 5, so they have self-selected. So if you biopsy embryos before day 5, one is you're more likely to get embryos that are, not good enough. But 2, because there are fewer cells, you're more likely to damage them. So even though the results will say the embryo is good, you biopsied it too early, and we see lower pregnancy rates from those biopsied embryos because they've been damaged. What's the utility of testing? We think that for young ladies who have potential to get a lot of embryos that go to day 5, if you test or you don't test, there's no difference in the live birth rates. The only difference is if you have more embryos, then you select the ones that are abnormal, you don't use them, and you use the ones that are normal, you're likely to get pregnant sooner because you have eliminated what is not right. So if you look at it from a point of view of saying, well, every cycle that is failed is so costly, then I might want to take the route of testing. But you will need to have so many embryos for you to do that. If you have few embryos, there's probably no benefit at all, because then you use them. Unfortunately, some will be abnormal. We may not know because we're looking at them under the microscope. So the microscope cannot tell you a genetic information about an embryo. We tend to see everybody following a cycle, whether failed or successful. So success